Good morning, everyone. We're so excited to have everybody here this morning to talk about the International Simulation Data Registry. My name is Linda Brown. I am an associate professor of pediatrics and emergency medicine from the Alpert Medical School of Brown University and Hasbro Children's Hospital, and have been working at the Lifespan Medical Simulation Center, which is our regional simulation center, for quite a few years now. And I'd like to introduce Aaron Calhoun as well.
And I am a professor of pediatrics at the University of Louisville School of Medicine. And I'm also on the board of directors for SSH. And I also co-chair the Inspire Pediatric Simulation Research Network. And we're really thankful that you've all come and have this interest in the Simulation Data Registry, and hope that our presentation today can both answer your questions and get you excited about what I think is really the next phase and how we gather and consolidate the data that we get in our simulations in a way that helps us move the whole field forward and our individual centers forward as well.
Great. I do have an other disclosure. I am a member of the American Heart Association Get With the Guidelines, recently the Quality Task Force, and now the Pediatric Research Task Force, as well as a member of the Research Committee for Society for Simulation Healthcare.
And as I said too, I also have several disclosures. I already gave those out.
So today we're going to just briefly talk, and hopefully this will give everybody an overview of the registry, but we're obviously completely open. Please reach out to us. I have my contact email at the end of this. But we will start with a brief overview, thinking about how we're linking simulation with reality and what this means, what the registry, sort of how it evolved, a brief introduction to that. And then really the guts of the registry. So we'll take you through what the input looks like and a little bit of what the output you will be able to get from the registry. And then most importantly, sort of how you can be involved. And we're really excited to see how many people are on the webinar today, because now that we're part of the Society for Simulation Healthcare, we're really excited to get as many people involved as possible. So as I said, this is a webinar on the International Simulation Data Registry. You can see our logo here, and we really are really about connecting data to life. And we'll go through some of sort of exactly what we mean by that in just a few slides. So Aaron?
So let's take you back to the beginning. We think it's vital that you have a sense of where this started. So let's go with a hypothetical case. Suppose that a patient is admitted to the hospital, they have pneumonia, they proceed to get a routine antibiotic, but they develop a flash allergic reaction to it, first time they ever received it, and they go into anaphylactic shock. Sounds like a realistic story so far, something that could happen. Code team arrives, they assess the situation, recognize anaphylaxis, and administer epinephrine per guidelines, and the patient's circulation returns. However, the code was prolonged, and there is a degree of significant neurologic injury. And as a result of that, a lawsuit is filed over allegations that epinephrine was not given fast enough, not given in a timely enough manner in this code to adequately preserve neurologic function. You direct the simulation center at this particular hospital, and you've been contributing over the past several years to the International Simulation Data Registry. Because of that, you have data on all of your anaphylaxis sims stored and benchmarkable, if that's a word, compared to both each other and to your own internal metrics. And so you decide to assist in this case, you're asked to assist in this case by answering the question, do individuals in simulation perform in a similar fashion as this code team did? What is the standard? What is a reasonable amount of time? And so after pulling the data, you note that the timed epinephrine administration sim for both your center and other contributor centers across the country, across the world, really isn't all that different. It's within a standard deviation. The numbers seem fairly similar. You feed this information back to your risk management department. This makes its way into the case, and the eventuality is that the suit is settled and the physician is exonerated and dismissed. Now, this sounds like it could be a bit of a far-fetched case. However, a case that has some similarities to this is in fact the foundation for this registry, a case that happened in real life. Almost every element of it has been changed, but the general outline, the general principle holds. And so this case began us down a path in about 2014 to see if we could begin to archive simulation data in a way that would both support return on investment, that would support center benchmarking and be an ongoing resource for research data, research quality data.
Sorry, I'm just trying to get my slides to move.
Oh, you're good.
Okay. Whoop.
Okay.
Hold on. I'm going to go back. Sorry, I was having a little computer issue. There we go. There you go.
So when we tend to think about healthcare simulation, we tend to think of it in a number of different buckets, right? We have training and assessment. That's sort of the first. We train our learners to do things. Perhaps we bring learners into a simulated environment and assess how they do the things that we train them on, or maybe how they perform in areas that we train them on other locations. Many places are moving towards in situ evaluation of code rapid response systems. You can perhaps envision a code that occurs on the floor, a unannounced in situ mock code where the whole purpose is not to teach or evaluate, although you might be doing that with individual learners, but to really get a sense of how the code system responds. And also just to take a look at clinical environments. Papers have been published on simulations designed to assess whether a new clinical environment or even hospital are moving forward well. Let's see, I think, did we skip ahead there, Linda?
Sorry, my computer is acting up for a moment.
Oh, you want me to load the slides?
Yeah, do you mind do it?
No, I do not at all. Can you send me the most recent copy though? Because I think you have the...
Yes, I will. You can keep talking, I will try it because...
Okay. So to move ahead though, the fundamental issue here is that in many of these situations, we're making some assumptions. We are assuming that people are performing in the real environment in a way that is similar to how they're performing in a simulated environment. We think this is a very valid assumption, but we don't have all the data to prove it. And another perennial question that we run into is how does this data get to us? How do we compare the data that we're getting in these various things to data from other centers to know how well we're doing benchmarked against centers nationwide, worldwide, in similar situations as our own? And how do we transmit this data from our personal databases in our simulation center to our administrators, to the C-suite folks, in a way that they will understand the value of what we're bringing to their organization? So at this point, this is really where I think the simulation registry sort of comes into its own. Have you sent the slides?
No, but I'm going to hope my computer works for a minute.
Okay.
So the Get With the Guidelines Resuscitation Registry, which is in no way officially affiliated with this registry at all, sort of evolved in around 1999. And it was really, once again, a real life registry that was looking at improving and optimizing outcomes for patients that had in hospital, for the most part, cardiac arrests, and looking at benchmarking and utilizing QI and knowledge translation and research to actually improve outcomes. And so when we were talking about this, the registry early on, the idea was how can we take the data from that registry and potentially use that to create this registry. So when we look at the current ISDR data, we track the following simulations. For the most part, and I'll show you some numbers later on, we are really looking at resuscitation, so true cardiac arrests that happen in the hospital. There are some difficult airway simulations and malignant hyperthermia simulations that were entered as well, and so that is a possibility if you have an interest in those topics. And once again, we used simulations and data definitions, which I'll show you the actual variables that really mirrored the American Heart Association Get With the Guidelines registry, so that we could then potentially even overlap and compare this against real life registries. We have the ability, however, to look at a lot of variables that other registries don't have the ability to look at, including really looking at systems testing and latent safety threats, education, and also using these to really hone down on specific aspects of data that we couldn't get from a real life registry, and I'll show that in a minute. We currently have 36 registered centers, and there's over 1,000 simulations that are currently entered. So that's approximately 100 per year, and we're really hoping that those numbers will continue to increase. These are the metrics that we currently collect. You can see here that there are metrics that are collected on, if you would call them demographics. So what type of simulator are you using? and specifically the situation that you are doing the simulation in. So are you doing it center-based? Are you doing it in situ? Is it announced? Is it unannounced? Because that way we'll be able to compare like simulations to each other over time. Was the purpose for educational reasons? Was it systems testing or research? And then case specific, these will not be surprising. There's a lot of really time critical actions, including how long did the arrest last for, the time to recognition. And once again, these are things that are really impossible to get in actual patient-based registries, because they tend to be sort of nebulous times. It's a time that may not be documented or may be actually hard to define. The time to the first effective bag mask ventilation, the time to the first time that somebody lays hands on the chest to perform CPR. So all of these are things that we will be able to collect, and we are collecting in the current registry. This is actually a picture of a mock code that has happened in our hospital here at Rhode Island Hospital. And this is an unannounced mock code. You can see here one of the facilitators is actually gathering data in real time on an iPad. And that data we then collect and
This is Jill.
into the registry.
Good.
Oops, somebody's not on mute. It wouldn't be a Zoom call unless somebody was off of mute at some point. And so here's an example of how you might think about an actual patient record versus our simulated. So on the bottom in the darker red color, you can see data that we would have in the registry, in our data registry. And an actual codes similar to the pink on the top. A lot of these numbers, as we know, may be entered even retrospectively after the event takes place. So even though we know the code was called overhead at around noon, for instance, really we don't know much else in terms of when exactly CPR was started, oftentimes when the medications were given. But in a simulated event where you're watching in real time, you know exactly when the mannequin loses their pulse. You know exactly when the first chest compression takes place or the first mask ventilation takes place. And you know exactly when the epinephrine was given and the dose of the epinephrine. So it really is a much more granular, detailed look at the data associated with this resuscitation. Looking at the demographics of the data, and this is data actually from fall of 2019, but you look at the data, the percent of, we have about, this was at around 939 data entries. About 65% of them are pediatric cases. Obviously, Aaron and I are both pediatric trained, but we're hoping that these numbers will hopefully even out as more data is entered into the registry. Most of the simulations were actually in situ, so within the clinical environment. And then you can see the case categories, not surprisingly, are a variety of pulseless arrest from VFib through PEA and VTAC and asystole, and then a much smaller number of cases with malignant hypothermia or a difficult airway. So Aaron,
right.
see if you can over.
Going to take things from here for a little bit. Make sure everybody can see my screen. Can everybody see the SSH website on the screen?
Yes.
Yes, great. Okay, so I'm going to take you on a brief guided tour of the registry so you can see what it looks like from the inside, how data is entered, and we're going to do this by making up a case, and we're going to enter that data. Now, one thing to keep in mind, we are going to share more at the end of this if you are interested in joining, and we hope you all are, about how to really become sort of onboarded, so to speak, how to really learn how to do this. So please don't assume that you have to remember anything you're seeing right now. This is a demo. This is to show you how it works. So the first thing to recognize is that this registry is a free member benefit to any member of SSH. You do not need an institutional membership. If you are personally interested, you can pull your institution along with you in this, and we'll tell you more about that later. But in order to get to the registry, you need to be signed in. So you can see I'm signed into my personal SSH account. If you go to SSH Resources and International Simulation Data Registry, you'll come up to the first portal page. You can see there's actually a link to our current webinar here, and at the bottom you'll see the ISDR directory. This is the members only section. If you click on that, that actually takes you to the launching pad to take you to the registry itself. So clicking on that will bring you to the main registry homepage. So You can see that you have the registry page here. There is information on what the registry is, news, as well as some other additional links that you can go to. But the main thing to look at here is actually the sites and how one can navigate to your actual data entry page. And we do have a test site. If you're interested in coming here on your own SSH webpage, feel free to enter and take a look at the test site. The test site has a global password, and if you're interested, let us know. We can tell you what that is. So I'm going to click on test, and that should, if all is working well, open up a login down below. I'm going to enter the code for that, hit enter, and it should take us to, I don't want to save that, and it should take us to data entry. So right now, it's a fairly simple system that enables you to put entry in on the types of codes and the types of SIMs we've talked about. Now, one of the things we'd love to do as we expand is to add additional different kinds of SIMs. And so I think there's a lot of potential for great expansion here, but I'm just going to go through a simple pulseless arrest data entry. So this is entered via Lime survey. This is just gives you the announcement, 34 questions, and hit next. This next page, once it loads, lets you add any information that you might need on the SIM that you're currently performing. So date of simulation, we'll just pick today. 9th, time of day. We round this down to the nearest hour. So anything that happens in the 11 a.m. hour from 11 to 11:55 counts as 11. So we'll put that as now. Mannequin manufacturer. This is actually how we get a patient age. So this is one of our demographic variables that lets us figure out how old the patient is. Are you doing an infant? Are you doing a neonate? Are you doing an adult? Is it an obstetric case? So let's just pick CAE Medi obstetric for sake of argument. Environment simulated. Is it the OR? Is it the ICU? And there's always options for others so that you can enter. So let's say, let's say obstetrics. And location, simulation center or in situ, you can enter either. Let's say simulation center. Number of participants, these are text fields, so I'm just going to tab through these and say that there's one of everything, but you can see that we're collecting data on really a number of different allied health professions that might be present, in addition to the option of adding other if need be. And I'm just going to put 0 for that. If you're looking down here below, you can see that we actually do have different codes that you can enter if you're missing certain bits of data. So you do not need to have every single piece of data to enter something. This is designed to be as simple as possible. And so there are numeric codes that the system filters out for missing data. I just don't have it. There are numeric codes for, well, we didn't actually do this in our SIM. It'll let you know that as well. And I'll get into those in just a little bit. Primary intent. This is an important question because it lets you say why you did the SIM. Is it education? Is it quality improvement? Is it research? Is it other? So let's say quality improvement. What was the overall setting? This gets at your institution. Is it an academic hospital, a graduate school, a non-academic hospital? It's an academic hospital. And then finally, this really helps us with demographics. From the perspective of the participants, was it scheduled or announced? And I hope that you can maybe see what this one really gets at, because simulations that are there to test systems are unannounced. Otherwise, you're not testing the system. Everybody knows there's going to be a SIM of some sort. And so this spread of questions lets us drill down at the data and say, okay, is this a scheduled SIM where everybody knew the kid would probably arrest or the adult would probably arrest? Okay, this is an educational SIM. I've got a couple fact checks so we know what bucket to put this in if you want to analyze it. Or is this an unannounced SIM in the real environment that nobody knew about? And it really might actually correspond quite well to what's happening in that area of care. It lets you separate and drill down, and we can cut this database any way that you need to get the data that your center needs. Finally is primary arrest date. I'm just going to do a VFib arrest just to show you how that particular module works. And you simply hit next. There. So all the data that we enter is in seconds, and they are all entered from the time of arrest. And that means the time that the SIM operator hit the button on the mannequin that made the pulses vanish, whatever time that is. You may ask or be question about how this data is measured, and the answer is it's designed to take any input that you have. Some people use the mannequin itself and time it based on mannequin states. Some people get this information from video. Others simply use a stopwatch. My center uses a stopwatch. It works just as well. So let's put the time of the arrest. Let's just put 400 seconds. Let's say it's a relatively short one. There we go. That's 4,000. There we go. 400. We collect data as well on time of event to recognition when people in the room say that there's a problem. Let's just say 10 seconds, they got it real fast. Time to initial attempt at ventilation. This is putting the mask on the patient and squeezing regardless of how well it works. We'll say 10. Time to effective, let's say it took them 2 minutes, let's say 120 seconds to really get a good seal. Same thing with CPR. They tried at 10, but they weren't really able to get effective compressions till about a minute due to, say, missing a backboard or something. Time of arrest to any attempted defibrillation, putting the paddles on the mannequin, let's say 3 minutes, so that'd be 180 seconds. First effective, let's say they did it right the first time. Now, as you can see down here, we also have tried to account for different things that may happen. Let's say that somebody, it's a shockable rhythm, but they simply forget to use a defibrillator. They go down a pulseless electrical activity pathway. You could put 9999 in there, and the system will automatically recognize that that is not 9,999 seconds. It means they didn't do it. You might not have this data. You can put 888 in there, 8888 in there, and the system will automatically recognize that you simply don't have that data, so it won't count for or against, whereas a 9999 might count against them if they were supposed to do it. 8888 simply knocks it out of the assessment. And finally, for something, let's say down here, let's say they come out of it at the very first defibrillation. You might not get to epinephrine, so you could put 4 zeros in here, and that would indicate didn't do it, but didn't need to. And I will tell you that when you put these 4 in, it goes down to 0 in here, but it does show up in the system as 4 zeros. It's just a side effect of the survey. And then finally, what happened? Did the mannequin die? Was there something else that happened? Was there return of spontaneous circulation? So you hit next. And then finally, comment field to allow you to enter any other information in that you might find to be useful. And then to submit the data, you simply click on submit at the bottom right of the screen, and the data enters the system. While this is in the test scenario, I could easily submit this. I'm just going to choose to exit out, so it's one less thing the system has to filter. But that's basically how the registry functions and how the registry gathers data. Now, the next question, of course, is how is this data displayed? And so, Linda, I wonder if you can take control back and go to the next slide.
I will do that. I also sent you the slides just in case my computer decides to lose its mind again.
Okay.
Since
it's okay, mine does too.
Has a moment of stress during this pandemic. Let me see if I can get those slides to work. It's looking promising.
Here, forgive the view of
there we go.
Forgive the view of my. Do you got it?
Yeah, I got it. So the register.
Okay,
Yep.
All right. So if you can just take that back over, and I'll kind of go over the data reports. So I think the biggest question now is you've gone through all this. Oh, I should add one thing. How long does it take to go through that survey? I am the personal data entry man for my center. And I can tell you that with the way this is set up, you can really get the data for one simulation entered in about 5 minutes. So it's not meant to be onerous. It's meant to be quick. It's meant to be simple. It's not meant to add a ton of overhead. You can, of course, add as much overhead to it as your center demands or needs, but you don't need to do that. This is meant to be adaptable. This is meant to be accessible by many. I'm going to stop sharing so that, Linda, good. So this just gives you a sense of what our registry reports look like. The first thing you will know, that you need to know, is that if you contribute data to this registry, you will get a report like this at least once a year. That once a year distribution time is February, March, and it gives you data on how well your center is stacking up or compared to other centers in several key metrics: VFib recognition, CPR, PEA recognition. We picked these because these are the most common ones. And it gives you a number of other statistics above. I actually send these whenever I get them to my hospital CEO and to the president of the hospital, simply to demonstrate how our center is doing compared to other centers. And so hopefully they'll continue to fund us. And so this is meant to be an initial, sort of a quick dashboard measurement of return on investment. I will say, though, is that you can also request specific data pools. This compares all of your data to all of the data from the rest. But let's say you wanted to know how your system's doing in situ unannounced mock code sims that might better correspond. We can do that. We have systems that can enable us to drill down and just pull those demographics out and compare those to the demographics that other centers have in that nature. So additional data pools during the year for whatever needs you may have is perfectly viable, and it's something that you would have access to as a member of the registry.
So just as a little, to highlight some of those value added that we're talking about is, you know, now we know that we're part of the Society for Simulation in Healthcare. So this is a free member benefit. And the provision of the yearly benchmarking reports that Aaron mentioned is really not only the ability to compare performance with other centers, but return on investment. I think anybody who works within the simulation community knows that that is a sort of an ongoing battle that we struggle with sometimes for institutions. And how do we prove return on investment for leadership? So I think that this is a great opportunity to leverage this data to show that there really is a true return on investment. And then once again, we're really building and excited to start asking some research questions around this data. We currently have 1,000 entries, and as we get more, we'll even be able to ask more questions. So I think there's a lot of opportunity there as well. So how do we become involved? Once again, it is a member benefit, and really the idea is to really just hopefully as soon as possible enter data in. So there is a process for orientation, and on the next slide I will have my email address, and I would ask that you contact me. We do have an onboarding process, and there is an ethics board proposal that has been passed through all of the different centers. It's been exempt as in every place that it has been proposed to. We recognize that some centers, their ethics board or IRB may not have as much exposure to simulation research. So we can also share letters of exemption that all the way back to Aaron's first exempt letter. And then really input data, and we can take you through some of that if once we get to that point. There's also, this is, really, we have a subcommittee within the research committee. And so if you're interested in being a part of this at the level of helping with onboarding or helping with quality assurance, because as this gets larger, we need to really start thinking about sort of processes for some of this. We've begun this, but we need to do more. And then research. Certainly if people have research questions, this is an opportunity to use this for that process as well. So here's my contact info, linda.brown@brownphysicians.org. But now's the opportunity. We'd like to have people be able to ask questions. And Aaron, I don't know if you can see the chart. I hesitate to move my mouse at all because I'm afraid I'm going to lose the screen, but I could probably stop sharing. Is anything in the chat, or if people have?
Yeah, well, I'm looking at the chat, and so there's a couple questions about permission and about using data registry for like a separate RCT or that approval. So maybe I can answer a few of those since I've done a lot of the onboarding over the past. So maybe to go into just a little more depth as to what onboarding means, to really enter data. So while this is sort of while this is a clear member benefit, that anybody can enter data into this that wants, we want to make sure that you are obeying sort of the logic of it so that the data remains as clean as possible. And so what we would need to do is, first of all, express interest. Let us know if you want and you're in. That's sort of the baseline part of it. To get in, we need to kind of just explain to you the data definitions. We have a data manual that explains what the data definitions are. We have a manual that shows how to mathematically interconvert for research purposes between the data we enter and data from Get With The Guidelines, if you'd like to compare, since that was sort of our seed data. We go over that at the first meeting in greater depth. We go over basically a longer version of what I did to show you that one data entry portal, except through all of the data portals that we have. I'm also seeing in the chat that there's an error when I attempt to download the manual, and there's a reason for that. This has recently been migrated to the SSH website, and so some of the links on that page are not still not active, although the link to the registry is functioning beautifully. If you would like the data manual, email Linda and I, and we will send that to you. We'll collect a list of people that are emailing that, and we will send you all that information. As far as onboarding then goes, is once you're comfortable with that, we send you our generic IRB proposal. So every center that has joined this has had to get approval through their local research board or IRB. I have not found a center yet that, once they understood that this was educational data not derived from patients, has not exempted this. I have the exemption letter for the original center, which is us at University of Louisville, to provide so that you can say, listen, the center that started this is exempting it, why can't you help? But that step can take a month or so sometimes. That's really the limiting factor. Once we have that, we go into the website, we add a site name and a password for your site, And then you have access to enter data under your site-specific name so that we know who you are, and can provide site-specific data for you. If you enter data in prematurely, then it either has to go under somebody else's site, which would throw their data off, or goes under test. And test is just a practice. If you enter something under test, the data is automatically factored out from any report. So it's the same as not really entering data. Couple questions on my email. Yes, I will absolutely send you my email as well here in a second. I'll put it up there. Is it possible to extract anonymized benchmark data sets also? So we have a process in the research committee for sort of non-contributor data extraction for research purposes. Our hope is that everybody who wants to take from the registry will give to the registry. That's sort of our operating motto. If you're giving to the registry, you get all the data we showed you. You can slice it any way you want. If you are interested in looking at registry data for research purposes, we would accept any applications for that, but that application would go through the research committee and be vetted by our team of methodologists just to make sure that the study that you're proposing can actually be done with the registry data, and to kind of basically help you to make sure that you're not asking the questions in a way that would be difficult to answer. And frankly, if you're going to use data from the registry, we want you to be able to be published. We want this data to be of use. And so we want to provide that level of review as both a courtesy and support for that. And Linda put my email right there. Yes.
And there are a couple questions about people, and people have put their email addresses up, which I think is great. If you can you can email me with the email address, because my intent is to soon send out an email to everyone that has said that they're interested, as well as the people that are already involved with the registry, so that we can really get a sense of everyone that's interested and be able to send out more information and future meetings, because we do have calls. I'll put my email. It's linda.brown@brownphysicians.org, but I'll put that in the chat as well.
I'll also say I saw an interesting question here on COVID, and the reality is we're in a different phase than we were when this registry developed. And so, Linda, I think one of the things that might be worth talking about as the registry gains momentum is how we can include options for virtual simulations or online simulations. I don't think we could include that in the actual database, because a lot of these are queued to things that you need to be physically present to kind of make sense. But I do think that's an area for development.
Yeah.
One thing to realize is that this registry, it was born in 2014. In just this past year, it was taken into the society and is now sort of a part of the infrastructure of SSH. So it's really at sort of the beginning of what I'm hoping is an accelerating growth phase. And so not only is there opportunity to contribute data, but there's opportunity to contribute ideas, time, interest. If you want to join us in making this the best thing it can be, jump in. We want that. We want to build this. Let's add new things. We have the capacity to do that. There's a lot that can be done with this.
Yeah, I think that's the most exciting piece of it. And I think I apologize for people if they've been trying to sort of, over the past year, we've been trying to get this migrated, and Aaron has spent a lot of time doing that. But I think we're really at the point now where we can really think about new ideas, increasing our volume, asking more research questions. So I think it's great.
Yeah, I was hoping we could do that in March, and then COVID hit. And so now we're just sort of, so.
There's a question, is there a place for assessing data from resource limited environments and facilities? So once again, that's a great question. We don't have, Aaron, last time I checked, I don't think we have any. These are all sort of resource heavy environments that we have.
They're all resource heavy environments. And so a lot of the things I'm hearing here are things I think we need to do. And so I'd say if you're interested in that, let us know. We'd love to have you jump in and start to build these things. There's a lot of contributing that can be done for those that want to contribute at that level. There's a lot of building to be done for those that want to jump in and start to take ownership of some of these things. It's a great opportunity to advance the field, and frankly, to advance your own career and plans of research and things of that nature.
Absolutely. And there's a question about, is it possible to export data to the registry from other sources? To avoid, if it's entered into another, I'm assuming local database or some other local, is it possible to export that data to the registry so that we don't have to, you can avoid, as far as I know, Aaron, we don't have any process for that, right? It has to be entered.
For doing what?
For entering, somebody else taking their data and exporting it in from another source.
We don't have a way to do that right now. The platform we're running on is a fairly straightforward, easy to access one. It's just Lime Survey. So we don't really have a way other than the data presentation itself to the survey itself to enter new data on board. We do have backup copies of this just in case there's any kind of failure that's on an Excel spreadsheet. So, but there's no way to upload the spreadsheet into Lime Survey. I think that, so a couple other questions here. There's one center that asked, what do we recommend for a center that may have been onboarded and experienced a change in employees? Email us. We'll start fresh. Yeah. That's fine. Don't have to get you a new site. You can have your old data. We'll just reacquaint you with it and we'll launch new. No problem at all. I think another question is, I really wish there was a way to do a bulk upload, and I'll tell you, there's also questions about other APIs. A colleague of ours, John Duff, up in Edmonton, Canada, has been working actually on some apps that might be able to do uploads for this. So those are areas of active exploration. A lot of this stuff kind of got put on freeze because of COVID, and hopefully we can get this going again. So these are all future things that we're hoping to develop, but we do not have one right now. If you have a video recording of the Sims, can we include retrospective data? Yes.
Absolutely.
Does not have to be future moving. You can put in any data that you feel merits inclusion and meets the inclusion criteria.
And there's been talk about how at some point, is it possible to actually include videos for centers that have videos? There is some work now on looking at latent safety threats, and I'm not sure how that's going to be incorporated within the registry. But then there's also even just sort of people, our center, for instance, collects data on quality of CPR and all of our mock codes. How do we, if we have that raw data, is there a way to also share that? So I think there's a lot of, as Erin said, there's a lot of opportunities. We're still in some ways really early on in this process. Now that we're sort of set and we know where we are, I think there's a lot of opportunity.
I would say that maybe to just expand on that a bit, Linda, that's exactly right. And I think that we've in the past discussed adding different modules to this. That's probably how this would happen. The nature of the database we have is if we change the CPR data too much, all the columns start misaligning. And so it's pretty tuned for get with the guidelines style stuff right now. But what we'd like to do is add maybe a low resource module, maybe a virtual sim module or a distance sim, maybe a QI module that includes QI data. And these would all be separate surveys that could expand the kinds of simulations we get. So a lot of possibilities.
And I know some people have put their emails in the chat. If you don't mind just sending those directly to us via email, just so that we don't lose people's information somewhere along the way, that would be fantastic. Retrospective cases, we said absolutely. We're excited to have retrospective cases uploaded. Let's see. Is there plans for translating it to actual resuscitations? I mean, I think part of the idea is, can we compare and contrast to actual patient registries at some point? That is the ultimate, that was the initial goal. I think there's a lot of other goals that we're sort of talking about now, but.
Yeah, I've actually, Linda and I have talked about that at great length, and it needs to happen. That is it's low-hanging fruit. I think the only thing that's in the way of that happening right now is that we need to get a better critical mass of contributors to make sure that our data is more representative for those kinds. Even though we have a lot of in situ, you might find that the definition for in situ varies a lot. I use in situ at my center in 2 different ways. I tend to do all my sims, even scheduled sims, in the clinical environment, so they're technically in situ, but the bulk of them aren't systems testing. And for that to really move forward, we would need to have a critical mass of systems testing sims. And so I think that today is the first step towards making that study a reality.
I'm not sure, what is GDPR? I'm sorry if I'm naive to that. There's a couple questions about that.
Sorry, this is Lucas. GDPR is it's an international requirement that if you capture data on any learner, you can't share it outside the country, and there's a hefty violation fine if you do that. So anything international wise, it creates a problem for sharing, even if it's research based. So I'm just curious how that's being handled.
Erin, I have no.
Yeah, this is the first I'm hearing about that, Lucas. I'm glad you're bringing that up. I did not know that that was An issue. It's never come up before. I would say that all data is completely aggregated, so there's no individual learner data that actually gets sent to anybody. But you're right, and actually all this data is taken in at the team level, so there's no individual learner identification in the system. But I think that's something that we need to look into now that you mentioned it, and I really appreciate it. Yeah.
No, thank you very much. It's good information.
Yeah, and Lucas, this is Kathy Adams. As long as we're not sharing any demographic data or privacy data on any of our learners, members, and it's just the numbers, I think we're okay. We've got a couple of people on our staff that are really versed in GDPR. I'll run it by them, but when they migrated this over, I think that was taken into account. I'll check though. Thank you for bringing it up.
That's great. That's great.
Yeah, that's very important. And I'm glad, again, this is the first I'm actually hearing about that. I'm same with you, Linda.
Yeah, absolutely.
Yeah.
I'm glad that I learned something new every day.
And I will say that we had an international group of individuals that were present at the founding of this. And so I'm surprised it didn't come up, but we will absolutely check into that. We have to make sure that we're obeying all international and national laws on data export.
And once again, it's great that people are putting their emails in the chat, but if you can also email them to me just so I can put them in a folder on and make sure we're all included. I want to make sure I don't miss anybody.
I think one thing to say too, just in reference to that, is again to say that the so far data that has gone to centers is an aggregate number. Actually, you don't even get the aggregate number from other centers. You get the aggregate of everybody else and yourself, much like in a registry like Virtual Picky or things of that nature. So the benchmarking data literally can't be dissected by individual centers in the way that it's being distributed now to find out individual learner information. That being said, the possibility exists of requesting an actual full de-identified data set, and I think that might be where the issues that Lucas rightly raised would need to be explored more. And Kathy, we can look into that.
Let's see. Any other questions? This has been fantastic. I think the main thing is obviously the follow-up to this. So I will aim to send out an email, and I will add that to the email of the people that are already involved, just as a sort of reintroduction to the registry, and especially if people are interested in being part of the committee in some way, then I will make sure that we have a contact so that we can set up a time to meet. Great. Do you have any other thoughts, Aaron?
I don't. If everybody kind of has a good sense of things, we're here to be to help answer any questions you have. We would love to talk to you more about this. I'm hoping we can really get a critical mass. We can begin to answer these questions and do these things. If anybody's interested in working on APIs, we know who to hook you up with so that you can begin to have those conversations and integrate with what's already happening. I think the possibilities for development here are huge, and we're looking forward to this really a relaunch as being a tremendous thing for the entire community of practice that we're part of. So thanks all for coming.
Thank you, everyone. This is great.